Now, the micronutrients can be broadly classified into the trace elements, the essential minerals, the water-soluble vitamins, and the fat-soluble vitamins. Iron, iodine, calcium, and magnesium are clubbed as essential minerals, which we as endocrinologists have much more interest in. Now, it's practically impossible to cover all the aspects of all these micronutrients within 30 minutes. And in fact, it would be much more boring if I keep on discussing the recommended daily allowances or the different diseases associated with these micronutrients. So I have divided my talk into 3 parts. I shall be discussing on thyroid and micronutrients, diabetes and micronutrients, and keeping in mind the ongoing pandemic, I shall spend 2 or 3 slides on COVID and micronutrients. Now, iodine is a classical example of a double-edged sword as far as thyroid is concerned. You think of any disease pertaining to thyroid, and I bet you will find that either on the left side of the slide or on the right side. Typical myxedematous creatine, an unfortunate outcome of severe maternal iodine deficiency during pregnancy. Though we could change his external appearances, the boy was left with significant residual mental retardation of real frustration for a clinician. So there lies the importance of iodine supplementation during pregnancy, because this is a completely reversible form of mental retardation. Now, leaching from glaciations, flooding, erosions deplete the surface soil of iodine, and most of the iodine is found in ocean. The concentration of iodide in seawater is around 50 microgram per liter. That iodide is oxidized to elemental iodine, gets evaporated, and comes back to the soil through rain. However, this typical iodine cycle is slow and incomplete in many regions. Thereby, the plant foods, they have varying iodine concentrations, ranging from 10 microgram per kg of dry weight in the iodine deficient soils to 1 milligram per kg of dry weight in areas where the iodine is sufficient. The native iodine content of most of the foods is low, and even the sea salts, because of prolonged sun exposure, have negligible native iodide. Now, different health organizations have put forward different terminologies. While the Institute of Medicine prefers EAR, or the estimated average requirement, AI, or the adequate intake, and RDA, or the recommended nutrient or the recommended daily allowance, the WHO relies upon RNI, or the recommended nutrient intake. The estimated average requirement denotes daily requirement of half of the healthy individuals in a life stage. I could not find any meaningful clinical difference between the RDA, RNI, or the AI. However, for the sake of discussion, the RDA stands for daily requirement of 97 to 98% of healthy individuals in a life stage. RNI denotes daily requirement of nearly all healthy individuals in a life stage. And AI denotes daily requirement of essentially all healthy individuals in a life stage. Personally, I think the RNI of the WHO is somewhat easier to remember. The recommended nutrient intake as far as iodine is concerned is 150 microgram for adults, and in pregnancy and in lactation, that is 250 micrograms. The iodine deficiency can be assessed by 4 parameters. While the median urinary iodine concentration, or the UIC, reflects recent intake in days, The intake over preceding weeks or months is reflected on TSH and thyroglobulin, and thyroglobulin is a more sensitive marker than TSH as far as median intake of iodine is concerned. The goiter rate in school-age children denotes long-term iodide intake over months or years. Now, if you look at the cutoffs of the lower cutoffs of urinary iodine concentration in pregnant women is less than 150 microgram per liter, and outside pregnancy, the values are same, that is 100 microgram per liter. As the breast tissue contains the sodium iodide importer and concentrates iodine, even in lactating women, the cutoffs are kept as 100 microgram per liter. However, it is important to note that all subjects with a spot UIC of less than 100 microgram per liter are not iodine deficient, because there is significant variation in day-to-day iodine intake, hence day-to-day urinary iodine output. TSH is a sensitive indicator for iodine deficiency in newborns, not in adults, because whatever fluctuation of TSH you get in adults with iodine deficiency, that is confined within the reference range of the population. Now, the goals of iodine deficiency disorder control in India were a total goiter rate of less than 10%, proportion of households using adequately iodized salt of more than 90%, and the median UIC in general population is more than 100 microgram per liter, and that of pregnancy is more than 150 microgram per liter. Now, if you look at the current iodine status, the percentage of household that takes the recommended iodized salt, that is 50 parts per million at the level of consumption, is around 76.3, somewhat below the target of 90. However, the UIC of the non-pregnant adults, the pregnant adults, and the lactating adults are beyond the cutoffs of 150 and 100 respectively. Concentrating on West Bengal, this is a study published by a group of people who are very close to us. They looked into 500 women, non-pregnant 200, and 100 in each of their trimesters. And the prevalence of iodine deficiency in pregnant women in West Bengal was less than 10%. The mean UIC was more than the cutoffs. And if I am allowed to dissect the study, the drawbacks of the study were: number one, they relied upon single measurement of the urinary iodine. However, it's recommended that you have to have at least 10 samples from different day to have an idea about the iodine status of the population with 20% precision, because there is significant variation in day-to-day iodine intake. Moreover, the number of the cohort was somewhat small, and it's recommended that in a school-based survey, you have to have at least 1,200 children to comment on iodine deficiency. But the salt fortification with iodine is the most effective way to control iodine deficiency, and most of the bodies recommended 14 to 65 milligram of iodine per kg of salt, either in the form of potassium iodide or iodate. However, iodate is more stable, particularly in presence of impurities, in presence of humidity, hence is preferred in countries like India. Over the years, we are encouraging people to take lesser amounts of salt, and it has been shown that even if the daily salt intake is less than 5 grams per day, people are not going to be iodine deficient. In areas where salt fortification is not possible, or in fact the people are reluctant or are not able to have access to iodized salt, the other options are iodized oil, either orally or intramuscular, or iodine drops or tablet. The American Thyroid Association recommends that women should receive at least 250 microgram of iodide per day, of which 150 micrograms should come from iodine supplements. Starting from 3 months preconception, should be continued throughout pregnancy and lactation. And all prenatal vitamin and mineral preparation should have at least 150 microgram of iodine, and the intake should not be more than 500 micrograms per day. Now, the recommendations for iodine supplementation in areas where there is less than 90% of the households are using iodized salt, and the median UIC is less than the cutoff of 100 microgram per liter in school and children. The options are: you give a single annual oral dose or an intramuscular dose of iodized oil, depending on the age, or you give the recommended nutrient intake or the RNI as per the age, either in the form of iodide or iodate. Now, the tribal women in Northwest Maharashtra, they do not consume iodized salt, and they are not compliant with iodine pills. So they have been provided with the life-saving dot, otherwise known as the Jivan Bindi, which supplies about 100 to 150 microgram of iodide percutaneously, and the dot has to be worn daily for 8 hours. Switching from iodine to selenium, the deiodinase enzymes are selenoproteins, and selenium is a component of glutathione peroxidase that scavenges the free oxygen radicals. Selenium deficiency has been associated with thyroidal damage, impaired thyroid hormone synthesis. Selenium works in concert with iodine, and the prevalence of Hashimoto's thyroiditis is somewhat higher in low selenium areas compared to selenium adequate areas as defined by a serum selenium cutoff of 70 microgram per liter. Interestingly, selenium supplementation has been found to decrease thyroid autoantibody concentration in the blood. However, if you focus on the clinical outcome data, concentrating on course of the disease, quality of life, the dose of levothyroxine, the data are sparse. We might be expecting an answer from the ongoing catalyst study. Selenium may or may not prevent postpartum thyroiditis, and that's why ATA does not recommend selenium supplementation in euthyroid TPO antibody positive pregnant women. Individuals with grave disease who are on remission with antithyroid drugs are likely to have higher selenium compared to those who are experiencing relapse, probably because of lower amount of TRAB in their circulation. The co-prescription of selenium and methimazole is associated with rapid achievement of euthyroidism, normalization of each component of the thyroid function test, and higher remission. However, this particular part is being addressed in the ongoing GRASP trial. Again, selenium has antioxidant and immunoregulatory properties, and we all know that reactive oxygen species, they have a pathologic role in thyroid eye disease. Individuals with grave disease and tau, they have lower selenium level compared to those with graves without tau. However, the data are conflicting, and an inverse correlation has been found between serum selenium and the activity score. Interestingly, we have an RCT looking into selenium supplementation in mild active thyroid eye disease, and selenium was found to be beneficial in Europe, an area with selenium deficiency. Though selenium may be effective in mild and active tau, the role is yet to be proved in moderate to severe thyroid eye disease. The flip side of selenium supplementations are selenium, particularly in higher dose, has been found to be associated with type 2 diabetes, peripheral vascular disease, all-cause mortality, and glaucoma. Now, this is the study I was talking about, a randomized, double-blind, placebo-controlled trial, about 150 odd individuals with treatment-naive thyroid eye disease who had euthyroid, had on with ATD, and had a disease duration of less than 18 months were included in that study, divided into 3 groups: selenium, pentoxifylline, and placebo. The authors did notice a significant improvement in quality of life, the clinical activity score, and they noticed a slowing of the progression of the disease. However, the proptosis and the diplopia score remained unaltered. The drawback of the study was that the selenium concentration in the study population was not measured. Now, another micronutrient which may not be in the true sense is associated with thyroid disorders, but may affect the thyroid function tests, having an entirely different diagnostic and therapeutic connotations. In 2016, we noticed a wave of publications focusing on interference of thyroid function test with biotin. The recommended daily allowance of biotin is around 30 microgram per day, which comes from a balanced diet. Hair and nail supplements contain much higher amount, and the amount is even higher in those being treated for multiple sclerosis. Now, if the serum biotin concentration is more than 10 nanogram per ml, and if you check the TFT in platforms using a biotin streptavidin reaction, then you are likely to get a falsely low TSH and a falsely high thyroid hormones, along with falsely high TRAB, and you may misdiagnose a case as Graves' disease. Now, unlike vitamin D deficiency rickets, the association between serum level of vitamin D and disorders which thought to be arising out of vitamin D deficiency is somewhat debatable. The picture is even blurred if you look at the clinical trials or the therapeutic trials compared to the observational studies. People got interested in vitamin D and thyroid because there is a strong homology between molecular structure of vitamin D receptors and thyroid hormone receptors. And the rat thyroid follicular cells, they have functional vitamin D receptors. However, the data is inconclusive as far as polymorphism of the vitamin D receptors, the vitamin D binding protein genes, and the autoimmune thyroid diseases are concerned. Some of the studies found a progressive decline in thyroid autoantibody with vitamin D supplementations, while others did not. Vitamin D level possibly is inversely associated with Hashimoto's thyroiditis, Graves' disease, and thyroid volume, which is even stronger in premenopausal women, highlighting a possible role of estrogen. The data is even more conflicting as far as the different forms of thyroid cancers are concerned. Some of the studies have found a higher risk of both differentiated thyroid cancer and medullary thyroid cancer in individuals with low vitamin D. The TPO, which is necessary for thyroid hormone synthesis, is heme dependent. So there is impaired thyroid hormone production in iron deficiency. Poor maternal iron store is associated with higher TSH and lower T4 in pregnant women with borderline iodine status, and coexistent iodine deficiency anemia blunts the efficacy of iodine prophylaxis, while iron supplementation in those groups improves this efficacy. Now, vitamin A inhibits or suppressed the TSH beta gene. Hence, in vitamin A deficiency, we expect a somewhat higher TSH, particularly in iodine deficient children. Coming to diabetes and micronutrients, glucotoxicity and lipotoxicity leads to excess formation of reactive oxygen species. And we all know that individuals with diabetes, they have an impaired antioxidant defense. So there might be a possible role of different antioxidants like vitamin C, vitamin E, and the beta carotene as far as reduction of insulin resistance and reduction in cardiovascular risk is concerned. Vitamin B1 or thiamine is a cofactor for different enzymes that facilitates glucose metabolism. Biotin in large amount may improve insulin sensitivity and glycemic control in type 2 diabetes. ADA has suggested that we have to look for possible vitamin B12 deficiency in long-term metformin use, and vitamin B12 deficiency and folate deficiency leads to hyperhomocystinemia, which might be associated with increased cardiovascular risk. Coming to the most debatable part or the most discussed part of vitamin D and diabetes, the beta cells, they express 1-alpha hydroxylase and vitamin D receptors, and low blood 25-hydroxy vitamin D is associated with elevated inflammatory markers, and elevated inflammatory markers may play a pathogenic role in the form in pathogenesis of type 2 diabetes. Impaired beta cell function and insulin resistance have been reported in individuals with low vitamin D and individuals with vitamin D receptor polymorphism. This inverse association between vitamin D status and risk of diabetes is somewhat strong in observational studies. Individuals with the lowest level of vitamin D have the highest risk of developing type 2 diabetes, which is even more pronounced in individuals who are otherwise at high risk of developing type 2 diabetes in the future. However, if you look at the Mendelian randomization studies, which frankly speaking, I have no idea about that, they neither support nor exclude a causal relationship between vitamin D and type 2 diabetes. While discussing vitamin D and type 2 diabetes, I shall be failing from my duties if I do not mention this particular study, which once again done by a group of people very close to us. They looked into about 100 individuals, gave vitamin D to those with pre-diabetes, and found that vitamin D supplement in pre-diabetes is associated with decreased insulin resistance, higher reversal of pre-diabetes to normoglycemia. However, once again, the study population was small. It was an open label study, and incident diabetes was not the primary outcome. In contrast, if you look at the RCTs, most of the RCTs are neutral as far as supplementation with vitamin D in the pre-diabetes population is concerned. The TROMSO, the DPVD, and the T2D are all neutral. However, a subgroup analysis of the T2D found that those with a significantly low vitamin D level, that is less than 12 nanogram per ml, may experience some benefit. Coming to vitamin D and type 1 diabetes, in preclinical models, hypercalcemic dose or a very higher dose of calcitriol have been found to prevent type 1 diabetes. There is significant association between low vitamin level in late pregnancy and not in first trimester of pregnancy with incident type 1 diabetes in the offspring. However, the longitudinal studies like the DAISY, like the baby diab, did not find any association between the vitamin D level and the risk of progression of type 1 diabetes. Some of the case control studies have found some benefit of vitamin D supplementation in early life with future development of type 1 diabetes. Zinc helps in assembly of insulin hexamers and thereby modulates insulin beta cell secretory function and perhaps insulin signaling as well. Higher intake of zinc is associated with lower risk of type 2 diabetes. However, over supplementation leads to attenuation of insulin gene expression and beta cell viability. Zinc deficiency needs to be anticipated in high-risk patients like those with uncontrolled diabetes, those who are on long-term diuretic use, or in elderly, and should be supplemented. Coming to chromium, supplementation improves glucose intolerance, gestational diabetes, and steroid-induced diabetes without increasing insulin concentration, particularly in chromium deficient patients. And once again, magnesium supplementation may enhance insulin action once again in deficient patients. Now, vanadium has been a focus as a treatment modality in individuals with type 2 diabetes and also in type 1 diabetes. This is a study from West Bengal that looked into a particular compound, a peroxyvanadate compound, and found that it may improve insulin sensitivity in preclinical model. The mechanisms are many. Vanadium improves insulin sensitivity, reduces appetite, and also reduces the rate of glucose absorption. So what about the recommendations of micronutrient supplementation in diabetes? Let me tell you, you do not have any reliable assay as far as estimation of the micronutrients are concerned. ADA does not support vitamins or mineral supplementations to meet glycemic targets or improve cardiovascular risk factor in absence of underlying deficiency, and daily requirements should be fulfilled from natural food sources as far as possible. Supplementations may be justified for special populations like women planning pregnancy, those who are having malabsorption like celiac disease patients, older patients, and strict vegetarians. However, consumptions over the daily requirements is not recommended. A group of individuals who are at risk of micronutrient deficiency are those who underwent bariatric surgery, and you need to supplement them with different micronutrients. Vitamin E has been studied in NASH. Apart from some improvement in the histological parameter, vitamin D does not lead to reduction in fibrosis score in individuals with non-alcoholic fatty liver disease and without diabetes. Now, all pregnant women should receive at least 4 micrograms of folic acid and 150 micrograms of potassium iodide. However, I hardly see any prescription having less than 5 milligrams of folic acid per day. And it has been found from a study done in India that low maternal vitamin B12 and high folate status may contribute to the epidemic of adiposity and type 2 diabetes in India, and they may also lead to IUGR. So we have to be a bit cautious while supplementing pregnant women with high dose of folic acid. Coming to the last part of my talk, COVID and micronutrients. Individuals who are prone to zinc deficiency and who are susceptible to COVID-19, they share a significant number of risk factors. Zinc has a role in immunomodulation and preservation of tissue barriers, and in zinc deficiency, you expect a compromised immune response and health vulnerable to viral infections, different viral infections, and COVID is not an exception. Zinc supplementation has been found to reduce the duration and severity of viral-related symptoms. And interestingly, mucor, they also acquire zinc through different zinc transporters. So over supplementations of zinc might lead to predisposition to mucormycosis. Coming to the mechanisms, improvement in the barrier functions, zinc is having antiviral actions, antioxidant actions, and modulation of immune response. However, once again, if you look at the clinical studies, the recently published COVID-A2J randomized clinical trial, they failed to show a benefit of either zinc supplementation or vitamin supplementation in individuals with COVID. There was no improvement in the primary outcomes, and there was no improvement in the secondary outcomes as well. Now, WHO has defined hidden hunger as a lack of vitamins and minerals, and that deficiency has to be overcome either by supplementation or biofortification or a staple food fortification, of which biofortification is the most difficult part to achieve. The Food Fortification Resource Center has launched a movement known as the Eat Right India movement with taglines like Sahi Bhojan, Behtar Jivan, or Sampurna Poshan, Sastha Jivan. So my conclusion or my advice to all of you would be avoid deficiency of micronutrients, get the RDI from a balanced and healthy diet, keep an eye on at-risk groups like pregnant women, elderly, uncontrolled diabetes, individuals having malnutrition, or individuals who are on long-term diuretics therapy, and supplement only if they are deficient, if you try to get a benefit out of micronutrient supplementation. Thank you. Thank you very much for your hearing.
Thank you, Dr. Partha, for your very elaborative talk. You have touched mainly some vital areas, which is now very much talked about. One thing I was wondering that you probably touched, but should be highlighted, that gestational diabetes mellitus, even in absence of any deficiency of folate, routine folate supplementation is practiced to avoid birth defects, particularly the neural tube defects in the newborn. That is one input from my part. And again, you have nicely touched upon the selenium. Now, in the iodine sufficient areas, the iodine deficiency is not there, and there is no marker of autoimmune thyroiditis also. Purely selenium deficiency may give rise to goiter formation, first recorded in Zambia. That is because of the coupling enzyme, some cofactor selenium plays. So that is two inputs from my part. Otherwise, they've touched upon so many areas, and in diabetes, poorly controlled diabetes, HIV poorly controlled, or they're undergoing total parenteral nutrition. So that's areas the vitamins should be properly balanced and should be looked into. So these are, otherwise we have touched to mainly the vital areas. So let us invite the questions, but due to positive time, too many questions may not be interpreted. Let us look into the chat box. Chat box. Okay.
There is no question in the chat box, sir. There is no question in the chat box.
So I think Dr. Partha has given us a very nice overview of the supplementation status. But one thing I would ask Partha, that the general practitioners routinely they give some sort of vitamin. The patient wants that give us some vitamins and all, and the practitioner also give vitamins and everything. That is adding to the cutting of pocket of the patient. Ultimately, the patient compliance is compromised. So that practice will have to some check, and that message should be percolated. The routine supplementation is never recommended in non-pregnant or except in some important areas. And rather the routine multivitamin, as you already alluded, the iodine should be checked before embarking upon the thyroid function test. Otherwise, the false interpretation will be there. So these you have touched upon, but these are the very vital areas often overlooked. So the problem is that endocrinologists or the diabetologists are not always consulted, because nowadays the routine general practitioners, they prescribe thyroid function test and they prescribe routinely all vitamins. Because just a couple of days back, I just had a patient reported to me that he is having COVID, and it's very early COVID, only just male sensations lost and COVID positive. And he has been given some antibiotics, some zinc, some vitamin C, all these things. And here giving one very important message that nowadays some papers are coming that in particularly some diabetic patient with COVID, over gym supplementation may be serious. That is the very bad side of the coin, because it may pave the way for mucormycosis. So with this, I profusely thank the organizers and our learned speaker. So over to the organizers.
Thank you, sir.
Thank you, sir. Thank you both for the excellent presentation and the discussion. Now moving to the next topic.